Good morning and good afternoon, everybody. Welcome to today's webinar, Managing a Measles Outbreak in Southwestern Ontario. I'm Jerry Hansen, Executive Director of IPAC Canada. Before we begin, I will be doing some housekeeping announcements. IPAC Canada recognizes that its headquarters are located on Treaty 1 territory, the traditional lands of the Anishinaabe, Ojibwe, Innu Cree, Oji Cree, Dene, and Dakota, and is the birthplace of the Métis Nation and the heart of the Métis Nation homeland. We recognize that we have attendees from all across Canada who may be in a different territory. From coast to coast to coast, we acknowledge the unceded territories and the homeland of the Métis and First Nations peoples. If you are in a group setting, please make sure that you list all group participants in the chat box so we can verify their attendance. Participants may use the Q&A for questions during the webinar. They will be answered at the end of the presentation. If there's not enough time to answer all the questions, they will be answered in a follow-up Q&A document. A recording of the webinar will be posted within 3 to 5 business days. The Certification Board of Infection Control has approved 1 IPU per education hour to be used for recertification. A certificate of completion will be emailed to attendees within 1 to 3 business days following the webinar. Customize it with your name and print it out or file in your professional file. All attendees may use the certificate for their regulatory requirements. If you do not receive the certificate within 3 to 5 business days, please contact us at info@ipac-canada.org. When you log off from today's webinar, you will be presented with a link to the evaluation survey. Please complete the survey. It does help IPAC Canada and our presenters plan future webinars. One attendee who submits an evaluation will be randomly selected to receive a $25 gift card. It's my pleasure now to introduce your moderator for today. Barbara Catt is with the Public Health Agency of Canada. She is also the current chair of the International Federation of Infection Control. Barb, welcome.
Thanks, Jerry, and it is my pleasure to introduce our current speaker, Managing the Measles Outbreak in Southwestern Ontario. And we have Dr. Nadim Khalil, who is dual board certified pediatrician, pediatric infectious diseases physician, both in Canada and in United States. And he obtained his medical degree from the American University of Beirut, completed a Master's of Science in Public Health at the London School of Hygiene and Tropical Medicine. And since 2021, Dr. Khalil has been dedicated member of the London Health Sciences Centre, where he currently serves as a medical lead for IPAC for the Children's Hospital. In addition, his leadership in IPAC, he provides expert through his clinical work in pediatric infectious disease. Please give Dr. Khalil, our IPAC Canada, warm welcome. Over to you.
Perfect. Thank you for that introduction. I do want to start and say I don't have any conflict of interest to declare, and I was just talking about our experience in London. I'm grateful for the opportunity to talk about what happened, but it's definitely sad that we do have to talk about the measles outbreak in the in 2025. It's sad that people are still refusing the vaccine and outbreaks happen. But first up, I'll talk a bit about the outbreak, why it happened, what it looked like, talk about a few challenges we saw at LHSC, and then finish up talking about the management of exposed individuals and concerns for congenital measles. So first up, talking about measles, it's a quite common virus. It's been around the world for several millennium, but it can be challenging to diagnose because first up, it starts with a normal cold before the rash appears. So sometimes it can be missed, and that's a tough part because it can be quite transmissible to other patients and other people around them. While the rash appears and that can be self-limited, some people do have complications. And the most common ones are pneumonia, brain infections, inflammation, liver dysfunction, and a few percent will end up passing away. I do want to bring up to the spots, especially on the right, and what we call complex spots. So these are quite specific to measles, and they usually show up in the cold-like symptoms in the beginning. But if somebody sees those, that's very suggestive of measles. From an IPAC perspective, we try to think about when people are contagious, and usually people with measles are contagious for 4 days prior and for 4 days after the rash appears. It is quite contagious, with approximately every person getting sick, getting 14 to another 20 people sick as well. And approximately 90% of people who are susceptible and exposed will become ill. We try to minimize that by using a negative pressure room and wearing a 95. The other interesting part, does have a prolonged incubation period of 11 to 12 days, and the rash usually appearing 2 weeks later. Testing was tough. So part of the challenges we faced early enough is actually getting people diagnosed with measles. It wasn't a common thing, and all the testing was going through the public health lab. So do want to point out that we do have a few different tests to think and to use. Usually people think about serology with the IgM, but that can take a few days after the rash appears for it to be positive. So it can be falsely negative early enough in the illness. Alternatively, we can use the PCR with the nasal pharynx or the urine reflecting the blood. That can be positive early enough in the illness. The good thing is, as the outbreak progressed, frequency increased as well, and so the Ontario Public Health Lab was doing the testing once a day for the PCR, and we were able to do serology locally every day as well per week. So talking about the Ontario outbreak, it's quite sad that this is actually one of the largest outbreaks that happened in North America. So since the 2000s. So the last biggest one was in Montreal with approximately 700 cases, and we've had 2,375 cases confirmed. This is not even accounting to patients that did not present to care or were missed or had minimal symptoms. And we have to ask ourselves, why did this happen? And that's definitely multifactorial, but there's big clusters of unvaccinated individuals where populations have low rates of vaccination and that were grouped together. We're not interested with other interventions and vaccination. We also have to account for the COVID-19 outbreak that popped up and some anti-vax sentiments that have increased since then. There's also lower acceptance of people getting the vaccines with current political climate, especially down south of the border. And a lot of time there's people not having access to primary care, which does add another barrier to getting the vaccine. And the other thing that's interesting with this outbreak, that this is the first one that was such a big scale that was with local transmission. Prior to 2025 and 2024 outbreak, most of these cases that were happening were being imported from abroad, people who just immigrated or traveling abroad and coming back sick. So the outbreak did start in the Atlantic and moved into Ontario end of the 2024, beginning of 2025. And as the number increased for us in January, February, IPAC did notice a big increase in number of these cases and did notify us, and we did reach out to public health. The good thing is it has been declared over at the October 6th at this point, so which is a good thing. There haven't been any cases in the last 3 months, which is good. So they were waiting for at least 42 days, so that's 2 times the upper limit of the incubation period before declaring that over. The other thing I do want to point out that while the peak was in the spring, this has been consistent transmission to community, which is consistent with a propagated source versus a point source. I do want to bring out a kind of cumulative outbreak case of what we saw. And so for people who are not aware of it, the Ontario map, London is based in the middle on the left, so close to the MSL. So Middlesex London, our public health unit. The vast majority of cases were situated in Southwest Ontario with a few cases up north. And the one thing that was kind of interesting and was a blessing in disguise is there was spread from one community to another. So this actually did help limit the impact on the healthcare system. And well, not everybody was getting sick at the same time and made it a bit easier to manage people. So talking about the cases, so quite a few of them were confirmed, and around 300 cases were probable because they were exposed or in the same community with symptoms but not tested. The vast majority of cases occurred in young children, so 75% of cases occurred in children less than 20 years of age, and the vast majority were under-vaccinated. It's always interesting to know that while parents are immunized or had contracted measles when they were young, infants themselves were not vaccinated. There were quite a few hospitalization with 12 ICU, and there was one mortality that I'll talk a bit about later on. As we do know, the MMR vaccine is quite effective, with 2 doses being effective, close to 97 to 99% effective. Some of that immunity does wane with time, and so it wasn't too surprising seeing 20 to 40-year-old getting a few breakthrough infections. The good thing is, talking to public health officials, there wasn't any transmission occurring after a breakthrough infection. So people that were previously vaccinated and getting sick had self-limited infections, while mild, and needed minimal support. But yes, so the vast majority happened in young infants. And the reason why this happened is while the adults were either vaccinated or sick, contracted measles when they were young, as the percentage of susceptible people in that communities was increasing, we were below herd immunities in those select communities and allowed transmission, especially people were going to communal or big events. So we did see outbreaks around Easters and weddings as well. So next, I do want to talk about what we saw at LHSC and the problems we faced. And I always want to bring it up that in pediatrics, the patient does not come alone. So usually they're surrounded by families, there's family members coming with them, especially young infants. You're not going to leave them alone. They need help with feeding or actually with daily activities. Usually you'll have visitors or other family members want to come and support. So the other problem is people kind of limiting that transmission from those family members. Then the next step was patients coming in, they're taken care by a large group of physician and support and nurses, which can cause transmission to them, or they can get sick and causing other people sick. Then we have to include the Children's Hospital, and at LHSC, it's unfortunately not a standalone hospital. So it is 150 beds out of 2 hospitals, separate hospitals, with close to 1,000 beds. We do have 155 pediatric beds with 11 ICU and 50 NICU beds. And I do want to bring up this picture because we actually face problems at every single step along the way. And so we had, and trying to implement any measures at the Children's Hospital or the ward was kind of difficult because it's not a standalone, so we don't have a physical space. But then talking about any measures at the rest of the community or at the doors of the hospital was a bit tough because this was a primarily pediatric problem. Talking to the adult providers or even public health, we didn't have that much of an issue locally. So actually, moving along to talking what happened to Middlesex, London. And as the outbreak progressed, it did feel like we were in the middle of the hurricane. So we are the white spot in the middle. This is London, so close, just south of MSL, so Middlesex, London. And didn't have that major local infections. So the rates of vaccinations are quite high in Middlesex, London, but we serve a big population where the outbreak was occurring. So as we noticed a big increase in number of cases, we did reach out to our public health officials and saying, we're seeing an increase in number of measles, there's a problem going on. And they were trying to be as supportive as possible, but from their perspective, they did not expect an issue in London because of such a high rate of vaccination. But on our side, we were worried of people coming in sick and exposing other susceptible people that could cause an outbreak locally at the hospital, even though we might not be seeing much in the city of London. And so I do bring up the vast majority of communities we serve, which accounted to almost 80% of all cases that were diagnosed during this outbreak. Middlesex, London was only 55 cases total, and a large number of those had their address in London, but actually living somewhere else and close to those communities. The big public health with the highest number was Southwest Ontario, and then Grand Erie being the second, and here in Perth. And this is the immunization coverage for Middlesex, London, but this is not the only place. So even with those communities where a high number of patients came from, the vast majority of people are vaccinated. They're still getting their vaccine. We're close to herd immunity, but it was these big pockets of under vaccination that were just spreading it like wildfire in those areas. So we did start seeing a couple of cases in January. So in the beginning of February, we started worried about the potential outbreak. We had, so IPAC did a great job there and kind of reached out public health. We talked to our administrators, we talked to our VPs to get people on board, and an emergency service system was kind of declared, and we grouped a lot of resources to see what we can do to tackle this, because the goal was to have zero transmission occurring in LHSC. We saw a total of 63 admission out of the 165. There was 7 ICU admission out of the 12 in Ontario. The vast majority were in pediatrics. We did have 10 pregnant individuals and 2 NICU babies. The vast majority of people were either admitted for respiratory failure, hepatitis, needing fluid support, and a few cases of encephalitis. So talking about patients, so people will either come in because they're worried that they're sick, they will come into our emergency room or our clinics and they have a cough, getting people sick. You're contagious for roughly 4 days prior to the illness, to the rash, and 4 days afterwards. And so what we were worried about is crowd control, basically making sure we're minimizing the number of susceptible people coming in and minimizing number of visitors. And the main goal was actually protecting our high-risk population. So these are individuals that are not able to mount a good response or not able to receive the vaccine, or if they got sick, they would actually have severe illness that could affect them in a bad way. So newborns and infants are not eligible to get the vaccine. We rely a bit on maternal protection, but some of that wanes fairly quickly. Oncology patients were worried, even if they were exposed, that can affect actually their care, because then you would hold off on chemotherapy because we're worried that they might get sick while we're giving them immunosuppressive therapy. And then finally, pregnant individuals are at high risk of complications, both themselves and for the babies. As we talked before, patients don't come alone, so they could get sick, their family members coming with them, and essential caregivers, visitors, and then staff themselves could get sick, or if they're coming in from other communities. We were worried about shared spaces, both in pediatrics and adults, about clinic spaces, our emergency room, and even the Ronald McDonald. So we kind of thinking about where different individuals and kind of stratify risk. We created a matrix to look at different areas and kind of the risk of people coming in sick and what people are going to be present in that area and what kind of measures we should take. First up, we want to talk about the patients themselves, and we elected to do active screening for most, especially on the children's and women's and emergency rooms. So thus our patients are more likely to be coming in sick, looking at what public health was sharing with us, as well as people that are high-risk population. Talking to adult side, they were worried on some of the high-risk units, but again, the number of adults that were sick or coming in was fairly low. One challenge we found was actually what to do with areas that had shared spaces. So some clinics, for example, like orthopedics, took care of both of pediatric and adults. So kind of how to manage measures for the children's side and the adults. And we tried to kind of balance, because some people would be uncomfortable. Why are we being targeted for screening and potentially some measures, but then the adult side, they're not doing anything? And then next step was actually looking for visitors, and we want to be a bit on the safer side on the children's side. So we did active screening and have questionnaires, including this one. So we were looking for something a bit more specific for measles, especially early enough, and the symptoms can be non-specific and can be just any common cold. So we wanted to see if somebody with a fever and a rash, any of the Koplik spots, conjunctivitis, and sometimes if they knew that we're being exposed or somebody around them that was ill. Next, we kind of were trying to, whenever it's possible, especially for chronic patients, for example, NICU or obstetrics, we're trying to figure out a proof of immunity. We do recommend for ourselves, Public Health Canada and Ontario, getting 2 doses of MMR vaccine received after 1 year of life. We will accept if somebody has IgG positive or if they've confirmed PCR kind of moving forward from now. Interestingly enough, the cutoff is somebody's suspected to be immune if they were born before 1970 because measles was still endemic at that point. And during our outbreak, 98% of cases occurred in individuals born after 1970. So it is actually quite a good cutoff. Next, for patients coming in, once they were suspected or diagnosed with measles, we want to make sure we're minimizing transmission for other individuals, given how measles is contagious and lingers on in the air. So we were ideally putting them in a negative pressure room with door closed on airborne precautions. But alternatively, if we did have a contingency plan, so somebody, if there was no negative pressure rooms available, using a private room with a HEPA filter and airborne precautions temporarily was an alternative. Thankfully, on the pediatric side, we had enough rooms and never had to proceed, but that was a concern on the adult side. The other thing we want to kind of facilitate is cleaning and kind of the turnaround time, given the limited number of negative pressure room, especially in our emergency room. So we contacted our facilities team and kind of reviewed the number of air exchanges and updated the FALS time. We tried to simplify it, so even though these are not 100% accurate to what could be used, we tried to simplify it to round numbers so other providers can actually follow these recommendations in a simple way. So we were recommending down to 30 minutes for turnaround time between patients and places where air exchanges were more than 20. And then just do want to point out that cleaning the rooms in the interim is allowed as long as people going in are wearing appropriate PPE and have proof of immunity. As we kind of chatted about in pediatrics, kids don't come in alone. They have essential care providers. And even though we had some kids that were coming in after they were diagnosed and they're suspected to be outside of their period of communicability, for example, somebody coming in with appendicitis now, we were worried about family members that could be incubating or sick themselves. And sometimes we've had to keep patients in those rooms as well, in a negative pressure room for a bit longer than the patient might need, just to minimize transmission from other family members. We did ask for people coming in if they're asymptomatic or have proven immunity, but sometimes that was not a bit possible. So we did ask family members to stay in the room if they didn't have proven immunity, and we were actually assisting them with providing them with food, similar to what we would do for nursing mother. So kind of at the doors, that was the benefit of, at least on the pediatric side, since we do have secured doors on our units because of safety for patients in general. So it was easy enough to set up somebody to screen individuals coming into those units at the door. We thought about actually doing some more measures at the door of the hospitals, but that was deemed a bit challenging, especially that on the adult side didn't have that much of a problem. The other ones was communal spaces. We didn't have we cannot police people going in, for example, to the cafeteria. We did ask them as much as possible. And similarly, we could not police people going outside the hospital to the store for if they need anything else, especially that some of these individuals were coming from a couple of hours away. And then finally, we did limit the number of visitors to 1 in high-risk individuals unless they had proof of immunity and were asymptomatic. And challenging part about getting proof of immunity is even asking people asking them if they have gotten the vaccine is not enough, because as the vaccine was introduced, there's a period of time between the 60s and the 90s where people was accepted to just get 1 dose. And then starting in the mid-90s, we actually recommend people getting 2 doses. So there were adults coming in their 30s to 50s who potentially only received 1 dose. And that's actually not enough. So they could be at risk of breakthrough infection. So we actually tried as much as possible getting actual vaccine records, but people didn't have those. People had moved away, they had immigrated, or people don't keep physical copies. So that was challenging. In some select people we did suggest serology. So somebody or the NICU or oncology or obstetrics, where they had multiple visits over multiple months, we did suggest getting serology, but that does have its limitation because false positive and false negative can occur. We tried to be as open with the community as much as possible. We did contact families prior to appointments, asking them if they have symptoms to reschedule or to switch to a virtual appointment. We posted signages at the doors of the hospital and the units in multiple languages, including in Low German. We sent letters. We set up frequently asked questions on our website, and we had multiple communication releases. So we made sure everybody was up to date on what's happening in the community and at the hospital. Um, Moving to another problem that we had issues with is actually communal spaces. Just because patients are expect to be in the waiting room in their room doesn't mean they're not going to be contagious in the waiting room. And this was an actual issue we had early enough in the outbreak. We tried to screen as much as possible, get the people out of the waiting room and kind of to the negative pressure room as early as possible. But after a few close encounters, we decided what else can we do? So early in the outbreak, we were triaging people after registration. So people were being registered, waiting back in the waiting room, then being assessed by a nurse. What happened is we've had a few close calls where people were potentially contagious waiting in the waiting room. So after a few events and we had to go assessing for potential exposure, we decided that's enough. What else can we do? So we suggested actually moving screening at the time of registration. So people that were failing screening were taken out to the waiting room and being triaged and assessed faster by a nurse. And then, depending on symptoms and what's happening, they were either moved to the negative pressure room or, if deemed less likely to have measles, going back to the waiting room. So other people that could get sick is actually staff. So we were worried from an occupational health. We want to make sure staff themselves were safe and want to make sure people coming in, they're not getting patients sick. The good thing is part of onboarding process, people are required to have proof of immunity or serology. So the vast majority of our staff had those at the time of the outbreak. There were a few that were grandfathered in from, they'd been around the hospital for quite a while. Those individuals were reached out to from occupational health and they did cooperate to get proof of immunity. And thankfully, we did not have any staff getting sick. One issue we got asked about is what about pregnant individuals? So in Ontario itself, there's no contraindication, there's no known limitation that somebody who's pregnant should not be providing care as long as they have proof of immunity. And theoretically, somebody who is working at the hospital should have that. But because of concern of breakthrough infection, high risk of complications in pregnant individuals, and potential complications to the baby, we did encourage alternative assignment whenever as possible because vaccine failure can still happen. Next, we were looking at the management of some of these exposed individuals. So in the unlikely event an outbreak, exposure did occur in the community or at the hospital, what else can we do to help prevent further complications? So one of those exposures did occur actually in our ID clinic. So we had a family come in for another reasons. Family had been contacted prior to the appointment. They declined any symptoms. They were screened at the doors, registered and came in, but then they were assessed by the staff. They realized they had a new rash that had popped up that day. Thankfully, this happened on a Friday afternoon. Nobody else was around, with a few number of patients outside, and we were able to assess everybody, and nobody were deemed to be susceptible, and we did not have any secondary cases. So in the setting of a potential exposure, what we want to do is assess people's immunity. So like we talked before, making sure we have 2 doses of MMR or serology or previous infection. If they were deemed susceptible, they should be isolated from day 5 to 21 days after exposure, or if we're able to get them in or identified within 72 hours and got the MMR vaccine, isolation is not needed. And that's, we have to be aware that's quite challenging. So part of giving the MMR in a timely fashion, that accounts to getting the diagnosis done in a time within the 72 hours. So the lab, even though they had ramped up testing, that can still take 24 to 48 hours, even longer on the weekend. Then we had to reach out to the family, bring them in, and getting the MMR. So a lot of time getting the MMR vaccine within 72 hours is quite tough. So people that are at high risk are eligible to get immunoglobulin, and that can be given up to 6 days from exposure. And that's going to be for high risk or pregnant individuals. So kind of we talked about for susceptible individual babies, we would give them immunoglobulin. Older babies from 6 to 12 months can get the MMR in the first few days. If not, they get immunoglobulin. And older individuals, even though it does say you can give the MMR vaccine, and this is from Health Canada, we need to be aware that if it's given beyond 72 hours, it's actually not that protective for this exposure. It's more protection for the future. So it does need to be aware that these patients might still have breakthrough infections and need to isolate and monitor for symptoms. And then immunocompromised patients or pregnant individuals that are susceptible would benefit from immunoglobulin. So just a quick summary of post-exposure prophylaxis efficacy. So the MMR should be given within 72 hours of exposure, which can be quite difficult because of the short time and the short window of giving it. It can be quite efficacious with 80 to 100% reported in the literature, but the problem is, again, that short window. Immunoglobulin can be given up to 6 days. It does have some challenges because of it's supposed to be given as an IM injection, and anybody who's worked and given vaccines, the dose is 0.5 ml per kilogram and up to 30 kilos. So somebody who's 30 kilogram theoretically is supposed to get 15 ml. A vaccine is 0.5 ml. And you would not give more than a couple of ml for injection for antibiotics, for example. So you'd actually have to think about giving 5 or 6 doses, 6 injections to get to that dose. And then we'd also need to account for efficacy in the literature can be variable. So a lot of the studies done in the mid 1900s had a higher efficacy because people were getting natural infection. So we suspected to have higher circulating antibodies in the donor, so a bit more effective. But versus nowadays, people suspect they have a lower amount of antibodies post-vaccines, and efficacy might be a bit lower. So because of breakthrough infection that can still occur despite immunoglobulin, people need to be isolated up to 28 days after the exposure. And then the next step is actually what to do and how to give the immunoglobulin. We had reached out to some of our surrounding hospitals and public health, and the reality was it's stocked by the blood bank. So it was difficult to give it in a community office. The other challenges we had is the supply. We all have a continuous natural shortage of IVIG. So that could be given to somebody who's older or bigger size, but we need to be aware of this limited resource. There's an adequate of IMIG, so immunoglobulin, given through the IM route, but the problem, again, like we talked about, there's a maximum of how much you can give per injection and how much people are going to be willing to take. The other part is people coming in on day 5 of exposure theoretically need to be in a negative pressure room. So that does put a bit of strain on our emergency room where these injections were given. And we did not have enough outpatient rooms. The other tough part we had is which patients to give immunoglobulins to. So severely immunocompromised patients, so people who just had their transplant or are getting chemotherapy, for example, that's a bit on the easier side. Even though they've had vaccinations in the past, we don't think they're going to mount an adequate response. and we would still give them the immunoglobulin. And then on the other hand is somebody who's getting a few days of steroids, for example, for asthma, should not be a long enough course, not high enough a dose to affect their immune system, and prior vaccination can still be protective. The challenge actually was in the third group. So this is somebody in the middle, which are getting biologics or had transplant a few years ago. There's unfortunately quite limited data about this and what to do and what's the best course. And some of that because when measles had been declared eliminated from Canada, we did not have these agents. So as we introduced these immunosuppressive agents and biologics in the last 2 decades, measles has not been circulating. So we actually have limited information on figuring out what previous vaccination means or breakthrough infection if they got a vaccine now. So a lot of times it was a discussion with the primary team, depending on what medications they're getting. And some of them did get immunosuppressive therapy or getting immunoglobulin if needed. The other big groups we face, even though we're pediatrics, we do help and take care of pregnant individuals. So interestingly enough, we did have a small exposure event on the Easter weekend. I was on call that weekend, so it was kind of worked out that way. But I do get a call from pregnant individuals that came in with a fever. They did not have a rash, but then within 24 hours of admission, had a new rash. So we had to backtrack and figure out who was in the waiting room when the patient came in and who else who might have been exposed. And that does vary a bit because the timing and what the next step can vary. So it's spouses could be affected, and then the babies themselves could be affected if mom gets sick. And given that this was a long weekend, we had minimal outpatient support, so public health units were closed, and we could not rely on family physician or primary care to help support giving it the MMR if needed, if they were discharged. And then trying to figure out should they get the MMR or IVIG. And that really depends if they were prenatal or postnatal. And we do want to bring out this was an issue throughout the outbreak, not just for us, because there was 51 pregnant individuals that were diagnosed with measles during this outbreak, and there were 9 congenital cases. So somebody who's still pregnant would actually receive, and susceptible, so without proof of immunity, they're at high risk of complications. They're at high risk of receiving mortality to the mom themselves. So they would get the IVIG, or if they're less than 30 kilos, IMIG, which would be quite unusual, versus somebody who's just delivered. We are less worried about their immunosuppression and would be eligible to get the MMR vaccine. And that's actually what we're able to do for those exposed individuals in our small exposure event. And everybody was able to get the MMR vaccine within 72 hours, which was quite a feat. I do want to finish and talk a bit about congenital measles. So even though this is an old disease and we're quite familiar with measles, this was a new problem, which we did not expect when this outbreak happened. So prior to the vaccine era, almost everybody had natural immunity. So almost all individuals by the time they get to childbearing age had protection. But nowadays, most individuals are getting the vaccine, they're protected through the vaccine, and we're not seeing that much measles circulating. But what happened is there was a small subset of people that were susceptible and being exposed for the first time in their life to measles during their pregnancy. And we really didn't know what that could be impacting the baby, especially. And we do know that could be quite harmful to the moms themselves. And this did have a bad outcome. We did have one baby that was born with measles that did pass away. I do want to point out that this baby was briefly at LHSC, then transferred to another center for other care because they did have multiple comorbidities and passed away for several months. So unclear how much measles did play a part, but it did contribute potentially to their ICU stay. And it was a bit of a silver lining because a lot of individuals, when they did hear about this mortality, did reach out to us. Okay, now we're worried about our babies, about our family members. What can we do to protect ourselves? So part of it, a lot of people in the community were less worried initially because there were not bad outcomes, but they saw this case reaching the news, they were more cooperative. So talking about congenital measles, so it is quite a rare complication. It's been very rarely described in the literature. So the biggest study had 10 babies across multiple years. We have limited information. There was no guideline available. We had reached out to public health, to other providers, other centers. They did say they'll work on a guideline, but the reality is there's nothing, there's no guideline, there's no data to base our guideline off. So we were a bit in the dark, and we had to create our own policy and our own recommendation to help minimize complications to the baby, and as well complications to the rest of other babies in there. So our NICU does have some open space. So getting any baby sick to the NICU, causing any outbreak, could cause high mortality to other infants. You'd have to potentially shut down the unit, minimize other admissions, just because it could be such a bad outcome to other exposed infants. And I do want to point out that a lot of these babies will end up having bad outcomes in the acute setting and long term. Early enough, they might have complications, including pneumonia, respiratory failure, hepatitis. And then we do worry about SSPE, that's rare complications, usually happens a few decades or so after being sick. But actually, with congenital measles, what's been reported, SSPE can happen within a few months to a few years after being sick, after being born. So, and that's unfortunately is non-treatable and associated with 100% mortality. So thinking about the different ways people could get sick, we kind of broke things down to different scenarios. So scenario was number one was what we thought was the bit more straightforward. This is a parent that had measles early enough in the pregnancy, didn't have any major outcome, and now the baby is born. So trying to figure out what happens to the baby, and sorry, thinking about the next case. So this one is actually a mom or parent has measles after the baby is born, a week after. So baby is exposed to the individual, and so we do want to give them immunoglobulin to protect them from this exposure. And we do want to isolate this baby for 5 to 21 days after that exposure, and up to 128 days if they do get immunoglobulin. We did get some pushback because a lot of these individuals were against vaccines, so they would be against blood product. So this was what I was talking about before. So these are pregnant individuals early in the pregnancy, so more than 2 months before delivery. So this can impact the pregnancy itself. So there's this risk of miscarriage, there's risk of prematurity, and there is a risk of actually pulmonary failure for mom requiring ICU care. So what we would do is actually monitor the baby for symptoms, depending on how long ago prematurity, assess for any other interventions. But most of the time, if mom was able to contain the infection, she'd have good enough antibodies to pass to the baby, and would just monitor for other complications of the brain for the baby. The tough part is actually was scenario number 3. So these are similar to the outbreak that we had, is mom coming in with measles at the time of delivery, so just prior or close to delivery, where mom with the pregnant individual does not have a robust immune response, does not have immunoglobulins to pass to the baby, and so the baby is expected likely to get sick. And we don't know what happens to the baby themselves, so they're high risk of complications. We don't know how long they're going to be shedding for. So congenital measles is usually labeled as somebody having measles within 10 days of birth. And usually that happens with moms getting sick within 2 weeks prior to delivery, and that can lead to severe congenital infection. Based on small studies, some people were giving immunoglobulin because it potentially could help as the babies are unlikely to mount a response themselves. But again, that was a bit experimental, and we did offer it because that's something that could be useful. But again, there's limited data on their efficacy. From an IPAC perspective, these babies were quite challenging because these babies were born potentially exposed at birth because of mom coughing or some of the amniotic fluid being aerosolized. But we were worried also if they were sick infected prior to the delivery that would be born contagious. So kind of keeping them in a ward to get other babies sick. So we want to minimize that. So we were recommending all these babies suspected to have congenital measles to go into a negative pressure room at birth. Well, that sounded like an easy recommendation. The tough part was how long to keep those babies in. Because a lot of time, what we do now with the PCR, we're assessing for the DNA presence. We're not culturing these viruses. So it's difficult to say, are these dead virus or actively shedding and could be contagious? And because there's limited data on literature, we kind of we recommended weekly testing with a PCR because again, we wanted to do a zero risk policy. And I do want to note that the baby that passed away with measles, even though they were a couple months old, to my knowledge, they were still testing positive close to that time. And given the limited number of negative pressure room, that can put a strain on the healthcare system. So, in summarize, even though this is an old pathogen that we're familiar with, the current healthcare system has changed. So we had to be flexible. We had to assess where potential problems could occur and to be flexible and adjust those. I'm happy to say with everybody's input and everybody's great support, both from IPAC, from administration and frontlines, we had zero transmission. The other good thing to note is even though we were trying to minimize visitors and family members coming in, none of the visitors, so we had no visitor coming in sick when the patient themselves were not suspected to have measles or confirmed measles. The other good thing is the vaccine works. So even though there was breakthrough infections, there was no transmission from previously vaccinated individuals. And overall, I think we were lucky with only one fatality in Ontario with that patient having multiple comorbidities. So kind of moving forward, what did we learn? And this is kind of my wish list because it's quite unfortunate that we had to deal with this measles outbreak in the mid 2000 in 2025. And I am worried that this is going to happen again in the near future unless we target this. So first up, we need to improve our vaccine rates. And it's a tough one because vaccine hesitancy is multifactorial and it does vary from one place to another. So we need to actively counter misinformation with public health messaging. We need to improve access to care, especially there's limited primary care in some post the COVID outbreak. We potentially need to implement an automated electronic alert, work with public health and clinics, have a walk-in clinic available every day of the week so people can come in if they want to vaccinate. You want to make it easy for people to get the vaccine. Next, I wish we have a vaccine registry. This can make it easier for us to assess who's had the vaccine, are they eligible to get the vaccine, because a lot of time we have to rely on family members saying we've got the vaccine, or yes, we've been seeing our family doctor getting the vaccine, but there's some missed opportunities for somebody coming in for any visit to assess if this patient could get the vaccine to be up to date. I do wish we had a more number of negative pressure rooms to be able to combat this outbreak and other future outbreaks that could pop up. And we wish we had better communication between different centers. We've had some individuals being transported to us or being transferred, and then en route to be told, oh yeah, this patient might have been exposed to measles or tested with measles. So we didn't have to account for that and put them in a negative pressure room, but sometimes it might be easier if we knew ahead of time. And then lastly, I do wish we had some more information on how to deal with babies born with congenital measles or immunomodulators. But I think for that one, I'd be okay because that means there's more measles happening and I'll be fine if we had less infections. So I do want to say thank you to everyone that's been supporting us. Everybody was great, and to us, big thank you to our IPAC team that helped combat this, all of public health and all of our providers.
Thank you so much, Dr. Khalil. I really, really love your wish list. I have to say, number one is the amount of or lack of immunization. And, you raised a great point there that this is something that proactively, I think we all need to be or have a role and a responsibility to activate for vaccination. I know even in your group, you had 89% that were unimmunized. I can't get over the amount of unimmunized individuals. And again, with some of them having bad outcomes. So again, you've unpacked so many um, levels of issues, which I love your presentation. I have a couple of questions that I'd like to address. Vidya, I know Dr. Khalil had actually answered this. Did you have enough airborne isolation capacity to manage admitted patients, especially in the pediatric patient?
Thankfully, we didn't have a major problem. The tower that we have our pediatric patients is relatively new, built in the 2010. So we have a decent number of rooms. I can't say we have that for the adult side, but thankfully this outbreak was predominantly on our pediatric and children. So we did pretty well, and we never had to, and we tried to cohort patients away from immunocompromised patients because we do have a shared floor and wards. The biggest problem with the emergency room, people coming in as the biggest port of entry, and they did great, and we didn't have any issues after we identified people at the registration, and the biggest problem was in the waiting room.
Right. Yeah, thank you for that.
Yeah.
And then just staying on that
Yeah.
negative pressure rooms, how many negative pressure rooms did you have available? And was there any issue getting patients into the appropriate isolation room? I think you sort of answered that, but
Yeah. No, thankfully our IPAC team did a great job of making sure everybody went to the room as quickly as possible, so we didn't have a problem. And again, we had to our knowledge, zero transmission occurring from patients coming in. We have approximately 6 in our ward, 6 negative pressure room on our ward. We have 2 in our ICU and 2 in our NICU, and 2 in our emergency room and 1 in our clinic. So fairly decent number, I think. So no major problem there. But definitely figuring out immunoglobulin, we thought about doing it in the clinic to take away from that impact on the emergency room, but we realized we don't have enough outpatient negative pressure room, and so that could be something we can work on.
Yeah, great, great. And thank you, John, for the question. Please provide updates regarding lab sampling procedures.
So a lot of that was pushed by Public Health Ontario Lab. We were recommending getting serology, so IgM and IgG, both assessing for previous immunity as well as active disease, because IgM is quite specific, but unfortunately not sensitive. So if it's positive, it's diagnostic, but if it's negative, you can still have measles. We did recommend a nasal and a throat swab for measles and a urine PCR as well. And those were sent out to Public Health Lab.
Great. Another attendee asked this question, are you still actively screening or will you be continuing with this practice for the indefinite future?
So at this point, we have dropped down active screening, and we are moved down to our routine infectious screening, which is checks for rash, fevers, and cough anyway. But now that the outbreak has been declared over in Ontario in beginning of October, we haven't had any cases. And I do point it's a good question because we had this difficulties figure out when do we actually take away measures. So when we're in the midst of it, when you're having multiple cases coming in every week, it's easy to say, yes, we need to keep these measures on. But what when you're seeing no cases for a couple of weeks in a row, and the number of cases in the community is coming down, can we take away? So that was a bit of a challenge. And we did actually have multiple discussions in July and beginning of August to take away some of these measures and actually say now we're back to more or less baseline community transmission, that we should be okay.
Another great question I had was, can measles be transmitted through breast milk from an infected mother?
Routinely, no. It should be more airborne, so it's a respiratory droplet. And to our knowledge, there are no case report, but we did not test any breast milk for measles PCR, but that would have been a good question.
Yeah. And then this one I really love is, if this outbreak reemerged tomorrow, what single system improvement, technology or procedural, would make the biggest difference?
I do want to say Public Health Ontario was great in updating us every week. They were updating the information on their system, on different units, different centers. That was a great, valuable resource to figure out where we are in the outbreak, what was going on, which communities affected. I think the biggest thing is testing, figuring out which one. And public health lab, the lab was great on ramping up testing. So pre-pandemic turnaround time is a few days. We were getting those either the same day or the day after for most cases. But I think
That was excellent.
But I think there's so much. It's such a complex problem. I don't think this. As you saw here, it was a multi-pronged approach because you cannot do one thing.
Yeah, exactly. Is the maternal, newborn, or pediatric profession starting to push measles vaccinations now?
They're trying as much as possible. And again, as we saw here, we're close to our 1995% target rate. But the problem is it's these small communities that are closed off. And they use religion as an excuse, but checking, there's no text that says, so people use religious exemption, but even though none of the religions actually push for that. And so it's really variable on who's the elder, basically, in those communities. So a lot of those, it's really one person that's pushing that misinformation and being against medical interventions. We are routinely recommending but it's sad because even when now we're talking about the RSV prophylaxis nirsevimab, and a lot of the documents you'll see it's a preventative medication. Nobody even sees it. For us, we used to talk about passive vaccine, but now people don't want to use the word vaccine because it has such a bad connotation. And it's so unfortunate because one of the reasons why I went to pediatrics and infectious diseases and do public health, work in public health and IPAC is because of vaccines. There's, I think, the greatest invention we have. And it's so sad that now people cannot even say vaccine. I'm ashamed to talk about people about their history of vaccinated, unvaccinated, because you're breaking that trust just even talking about it because you're just so confrontational, and it's disappointing.
Another great question. What definitions did you use for severely immunocompromised, or was this assessed on a case-by-case basis?
Yeah, if you want, I can share a document if you give me a minute. That was based on a document from NACI. They have a great table.
Okay. Yep.
I can pull it up for you if you give me a second. It's a bit of a busy slide, so I didn't want to overwhelm people with that information. And I do have a quick summary for us here. Share. But yeah, I do suggest looking into that NACI document. It's much more extensive than this. But what they do suggest is somebody who had a transplant recently in the last 12 months on CAR T cell, they point out acute leukemia, even though we think AMLs can be pretty bad, somebody who's on AIDS, primary immunodeficiency, anti-suppressive medication. But it's quite a big list. And it can be variable. And a lot of time is in the group two, is we don't know what the impact is on previous vaccinations. So people who are less immunosuppressed getting their potentially vaccines, they might have some immunity, but it's really depending on how sick they are, how many medications they're getting, and how worried you are.
Right. Another great question. Have you received patients from long-term care home or had the outbreak in a long-term care or heard of an outbreak in a long-term care home?
My work is primarily in the acute setting in the hospital. We didn't have too many patients coming from those, and to my knowledge, no major outbreak happened. I was in close contact with other hospitals around us, but not with long-term. Interestingly enough, actually, we did have one of our kind of mixed clinic, which they take care for some of developmental kids and autism that are almost a classroom setting, and kind of figuring out what measures can we do there, because they're technically part of the hospital, but they're almost a school-based system, but also kind of minimizing transmission there, because somebody who's potentially susceptible missing 3 to 4 weeks of schooling actually sets them back tremendously, and even they actually would be taken out of that program, and so it would actually be quite harmful. So kind of we had again quite a variable population, but nothing for long term for us.
Right. No, that's great. I'm cognizant of the time. There's still a couple of more questions. Would you be okay? We pose these
I
to
have a few
you
more minutes. I
and
think we can
then,
give another
yeah,
5 minutes.
another 5 minutes. Jerry, are we
Yeah.
good with that? Okay.
Yes, go ahead, please.
Okay. In terms of content, is there any difference between the registration measles screening question versus screening at triage? The current,
More or less,
old versus new.
I think they were a bit more or less similar. The only big difference is even somebody who's vaccinated, breakthrough infections can still happening. So we were a bit more cognizant of symptoms at registration. And then if somebody was exposed, but potentially still early enough, had the benefit of time to kind of put them in a negative pressure room versus we were worried more about adults coming in, even though they were asymptomatic, still in that incubation period. And I think a lot of time was we didn't know what's going to be, what we didn't know what those population looked like. We didn't know how the adults' immunity, because again, we all mostly have from public health, it's school age vaccine rates. So we didn't know if the rates of these adults in those communities, if it was high or how much they were getting infected. So we wanted to be a bit more aggressive and limited visitors. But again, the good thing is none of the visitors came in ill when this child themselves were not suspected to have measles or confirmed measles.
Another great question. Could optimizing the timing or dosage of passive immunization improve protection and reduce possible complications in non-immune pregnant women exposed to measles?
Yeah.
Oh, yeah.
So it's really timing. Some people now are looking at the safety of MMR, even though it's a live vaccine in pregnancy, and seems because it's every once in a while it's inadvertently given, and the data support is reassuring that it's safe, but people are less worried it's more of a safety effectiveness because we don't want to cause harm when we give the vaccine. The challenging part is, yeah, you have those 6 days. Beyond that, the efficacy goes down. You can still give it as potential for if it's off-label, I would say. So a lot of it is figuring out diagnosing the index case as early as possible and then contacting exposed individuals as early as possible.
Right, thank you. There appears to be support with an organization for universal airborne protection. For example, upper air UV in common spaces like waiting rooms and patient rooms. Would you be in favor?
Uh, it's an interesting question. There's definitely a lot of push from some IPAC and kind of uh, people who manufacturers for those. And in some setting, it seems it's a bit of gray. Some people seem like it helps, sometimes it doesn't help. Um, I think it's with measles kind of difficult because we've moved away from culture-based testing, so it's really hard to figure out how much it lingers on, how much people are it's in the air, and kind of figuring out efficacy. So that's the tough part. And if you do a PCR, even though it's dead from the environment, you're still positive. I I do want better studies before we commit to any of those measures, especially they can be costly. And our healthcare system in Ontario is quite weakened by funding. And so adding any extra cost is quite challenging without really robust data.
Very good. And last, any lessons learned that could help prevent similar outbreak from happening or effective containment? Let's go into your
Uh,
wish list. I love
I
it.
think that's what
And
my wish list is prevention. The number one and the most
right.
effective and the most effective is vaccine. It's effective, it works, it's
Yeah.
safe. If people we haven't had any issues in the last 30 years in Canada before this outbreak, and a lot of it is linked to lower rates of vaccination in these population. And even though these are closed off population, and now we've had high number of bursts there, so you kind of diluted people who were immune. I think that's why. But if you don't do anything about it, in 20, 30 years, these kids are going to become adults. Their kids are going to be susceptible. You're going to have a new significant percentage of that population being susceptible. You're going to have another outbreak. But the big thing is,
Yeah.
yeah, vaccination,
Yeah.
counterbalancing misinformation, and
And 100% I agree with your vaccine
yeah,
registry. I think that really demonstrated a lot of gaps between provinces and territories.
yeah,
And I said one last, but there is another
yeah.
one. If a person received one dose only of the vaccine, will it result of the serology evidence of immunity?
Yes. So the measles being a live vaccine, the second dose is actually not a booster. So the efficacy of one dose of MMR is around 90%. So with the first dose, 90% of people are getting protected. And so, but because it's difficulty getting serology testing on everybody who's had the vaccine and potential false positive and false negative, people have decided just give it another dose, given it's safe. So what happens is those 10% who didn't respond the first time around, almost 90% of those will get another response. So the combined immunity is 99%. So each dose gives you a 90% protection. But yes, theoretically, if you get better sensitivity and specificity of your serology, one dose is effective, which is why people did one dose from the 70s to the 90s before pushing to two doses when WHO and Canada was pushing for eradicating measles.
Another question, is indeterminate considered to have received the vaccine?
I think that's by definition is indeterminate, and I would, depending on the patient and population, so definitely somebody who's immunosuppressed or you're worried about they're taking
Factors.
medication that's affecting their system. So kind of we talked. So
Yeah.
given in the group two, one measure is you
Yeah.
could do check serology, and then if they're positive, not to give, or if they didn't respond, their IgG is negative, give immunoglobulin. So if it's indeterminate and you're worried about risk factors that they could get severely ill, then indeterminate is not enough.
Right. Well, again, I really thank you for this great presentation. I'm not sure if people are aware, but Canada is on track to lose its place among the nations that have eliminated measles. And our international health officials are convening this week to review this designation. And I think the next target as well is United States and Mexico. They're having or experiencing very similar measles outbreaks that we've experienced here. And again, it was my pleasure. I really appreciate hearing more about measles, like you say, the disease that should be long gone. and, appreciate the talk again. Thank you, Dr. Khalil,
Right.
on behalf of BIPAC Canada. Don't
It's my
forget
pleasure. And
to please make sure that you're following up with the survey, please, the results. Thanks again.
Sure.
Bye, everyone.
Thank you,
Yeah.
Dr. Khalil, and thank you so much, Barb, for moderating. Thank you, everybody, for attending. Have a great day, and the webinar is now adjourned.